I am so excited today to have my buddy, Dr. Corin Menn, here to talk about all things breast cancer and hormone therapy. So, Dr. Corin Menn is a board certified OBGYN. She is a certified menopause doctor through the Menopause Society. She's also a 23-year survivor of breast cancer and premature menopause, is a BRCA carrier, and uses her own personal experience to help women navigate their own healthcare challenges. She's dedicated to her practice to menopause management and the unique healthcare needs of female cancer survivors and those at high risk for breast cancer. She now practices exclusively through telehealth. Dr. Menn provides women's health consultations throughout the country. She is also a medical advisor and prescribing doctor for Alloy and Menopause telehealth platform. And she's an active member of the Menopause Society and a fellow of the American College of OBGYN. She's amazing. Everybody loves her. She's got a great presence on social media. That's how we met, and we are friends in real life now, which is awesome because we met at many conferences at this point. So, and I love collaborating with her because she always brings such great insight to everything that we do. And so far, I've been interviewing patients to talk about their journeys, and I wanted to incorporate, clinicians and their expertise. And now we've got both in one with Dr. Menn. So please, everyone, welcome Dr. Menn, and we are going to get into it.
Awesome. Thank you so much for having me. And really, this is the whole reason for my mission, is that it's my experience as a patient has deeply informed and transformed my career. And I think finally I'm almost 51 on Sunday, I turned 51. At 23 years being a breast cancer survivor, I really have found my groove and my calling and my mission going forward, which is to kind of advocate for the most vulnerable women, which includes young breast cancer survivors in particular.
Yeah, absolutely. And I think that, they oftentimes get dismissed and not enough attention goes to the breast cancer survivorship and thrivership, right? Like it's all about surviving and you should be happy you're alive versus, hey, I need to thrive in my lifetime and have a good quality of life. And so we like to call them
Yes.
we like to
Thrivers.
say thrivers, yes. So, we're going to talk about your journey, however much, you've been so great on social media, kind of like, explaining everything to patients. I've had patients tell me like, oh, do you know Dr. Menn? I saw that you on Instagram. And so, I think that and the way that you explain things are so clear for so many people that it's been amazing just to even follow you along. I guess the first question that I wanted to ask you, because this is the thing, even like no matter how many times I post about vaginal estrogen or estrogen, and no matter how many times I can say it because of the stupid black box warning, I always have a patient say, well, does estrogen cause breast cancer? Do hormones cause breast cancer? I mean, this is always the number one worry. We always say, heart disease is still the number one killer in women, but women are fearful the most of breast cancer. So let's answer that first, Dr. Menn. Do hormones cause breast cancer?
No, they do not cause breast cancer. And at this point in time, this is not an opinion. We have decades of data, both, in the cancer literature, the menopausal hormone therapy literature, and we can say menopausal hormone therapy does not cause breast cancer. And if you got breast cancer, right, your hormones didn't cause it, right? If you have estrogen receptor positive breast cancer, this is a very basic bit of information everyone should understand. If you have estrogen receptor positive breast cancer, it just means your breast cancer cells have retained the receptor to estrogen. All of our breast cells, your breast cells, you don't have breast cancer, right? Well,
Right.
your breast cells right now have estrogen receptors on there. Okay. So
In
if
fact,
some of
from
those,
head to toe, wouldn't you say we have estrogen receptors all over our body?
everywhere.
That's why menopause is such a big hit.
Exactly. So if you develop breast cancer and your type of breast cancer, your cells, when they look at it under a microscope and in their lab test, they can still see the the estrogen receptor. Then they're going to call it estrogen receptor positive breast cancer. Doesn't mean that estrogen caused your breast cancer, period. And it also doesn't mean that you can't use vaginal estrogen to treat your genitourinary symptoms. And then today, we're also going to talk about what about systemic estrogen after a breast cancer diagnosis, which is like the third rail of medicine that nobody wants to talk about, but we need to.
Clear. And I think there are oncologists that are pretty much on board with the fact that the use of vaginal estrogen or vaginal DHEA in the vagina for genital urinary syndrome and menopause, which, as a reminder, is that urinary frequency, urgency, frequent UTIs, vaginal dryness, pain with sex, vaginal discomfort, all of that that can impair your quality of life, that most everyone in the world could take it without much problem, without much difficulty. And I think we can say that for breast cancer survivors. I think we can say that for patients who have heart disease. I think we can say that across the board because there is no systemic rise in your estrogen levels using these medications, correct?
In fact, we have said it. The North American, now the Menopause Society, ACOG, ASCO, they all have clear guidance on this that says it can be used, right? Their language is conservative. They say after consulting with your oncologist, you can, but the reality is it's in their practice guidelines. And there's so many studies just recently that have been published, review studies, and um, a number of important things in literature that have confirmed the safety of it. And yes, even in estrogen receptor positive breast cancer, yes, even if you're on tamoxifen, and yes, even if you're on an aromatase inhibitor. If you're on an aromatase inhibitor, we may choose to be extra cautious and use maybe a little bit, even there's some lower dose vaginal hormone products or vaginal DHEA, but there is a role for using that and you don't have to suffer, right? So we can just move on from that because it is clear. There is no controversy.
There's no controversy with that. So, for those of you listening, check that off because we have said this
Yeah.
time and time again. But what we want to get into a little bit more is really around like patients who are now thriving past breast cancer. They've survived the treatment, they're thriving in life. They may be young, like yourself, who got diagnosed at a very early age. They may be older, whatever the case may be, but now they are surviving with no evidence of disease. They may or may not have estrogen positive status. What are we want, and what do you think, or what's the next front? That's the next frontier for breast cancer survivors.
Yeah, it is. And so let's just first identify the problem. And as what you said is that we've got a growing body of survivors, right? We've got about 4 million breast cancer survivors in the US alone and growing, okay? Every year it's about 300,000 new invasive breast cancers that are diagnosed and more than 55,000 DCIS cancers that are or DCIS cases that are diagnosed. And the incidence of breast cancer is increasing at 0.5% every year, right? So you've got an army of, like you say, thrivers, and it's getting bigger. And in addition to those thrivers, we have a lot of previvers that are kind of, in this gray zone. These previvers are women who have either a very strong family history of breast cancer or they carry a BRCA1 or 2 mutation or other genetic mutation. And so the issue with these thrivers and these previvers is that they're entering menopause either naturally or prematurely, and in many cases prematurely from either chemotherapy, the effects of hormone suppression, ovarian suppression, and then being given an aromatase inhibitor, or just having their ovaries removed. In the cases of breast cancer survivors, they may have them removed for a variety of reasons, or for previvors, they're doing it as a prophylactic reason to prevent ovarian cancer. So we basically have all of these women, and we're ignoring the big elephant in the room is that they are all going to go through menopause at some point, right? So what are we doing with that? So there's a huge discussion in the general population on just general menopause management and kind of celebrating that we should really embrace hormone therapy and that really understand that for the vast majority of women, the benefits far outweigh the risks, and there's so many health benefits. But what the problem is this army of women I'm talking about, they're being left out of that conversation. So they're like, well, what about me? What about my bone health and my cardiac health and my brain health, right? What are we doing, right? And then the problem is even more kind of severe. It's not just like, what am I going to do in like, menopause? The data on premature menopause and what those impacts, what it does to your preventative health is really not discussed with these cancer survivors, right? So big study, the Mayo Clinic cohort study of oophorectomy and aging, all right? So, and then also the nurses' health study. These showed, here are the quotes we've got, 67% increased risk of all-cause mortality, mainly driven by cardiovascular disease. This is all driven from premature menopause and the ill effects, right? But also increased risks of depression, arthritis, asthma, COPD, osteoporosis, hip fracture, mood disorders, sexual dysfunction. Okay. So we basically are artificially making women, menopausal earlier or natural menopause. But these earlier patients have these very significant health risks. And we know many of those health risks could be mitigated by the use of estrogen therapy. Because you and I both know in a premature menopause patient, so someone who has menopause prior to age 40, 45, 40, right? That the standard of care is they get full replacement hormones at least the age of natural menopause because their health risks are so high. So, how can we reconcile that with our breast cancer survivors, right? We have to balance the risk of breast cancer recurrence and mortality. Of course, that's what we all want to live, right? Against all of the collateral damage that is more than just a bothersome hot flash. Like we're talking about real serious health risks that are being thrust upon this survivor population. And so I think we first have to just like, what is the problem? Because some people are like, oh, it's just a hot flash. Exercise more, take something non-hormonal for your hot flashes. Those are really important things that we need to talk about. Absolutely. But you're still ignoring that those things are not going to lower that dramatically the risks that we just named, right? Like we really need to, and I think women, young survivors in particular, we've been dealt a hard blow. We've had to interpret and kind of make a lot of very hard decision weighing risks versus benefits. We have to decide lumpectomy, mastectomy. We have to decide on chemotherapy. We have to decide on adjuvant endocrine therapy. We have to decide on reconstruction. We can handle the conversation of risks versus benefits. And oncologists in general are very good at a risk benefit analysis because like that's what they have to do every day to explain to patients, this is your risk of recurrence. If I give you this medicine versus this, all right? So there's no reason why they shouldn't also be able to do that. Once someone has completed their primary treatment for cancer, that's what we're talking about today. People who have done your cancer treatment, okay? You're finished, you're done. We're not advocating that anybody forego some of these life-saving treatments. But when you're in this next phase, you deserve to say, okay, what am I going to do for the rest of my life? How am I going to manage it? And what I find, and tell me what you see in your patients, is that even the option of having a discussion is off limits. It is completely shut down. There is no option. When they say, what about HRT? No, categorical refusal and say that the data just says it's dangerous. And that's what they're told. And that's what I found. And then patients are like, well, my oncologist said no. My GYN says they have to defer to the oncologist. And then so the patients are just left in the lurch. That's what I find. What do you
Absolutely. Absolutely. And I mean, if you think about it, okay, we have these thrivers that have, overcome this breast cancer diagnosis, and many of them, higher stage, whatever, and they're doing well, and maybe they're in their early 40s. And all of a sudden, you're going to let heart disease kill them. You know what I'm saying? Like, that's still going to be the number one killer in their situation. So, we're talking about longevity and quality of life as well. It's not only just, overcoming the breast cancer and knowing what your risks are, but I do find that it's always a hard stop. And of course, our government has a lot to do with that, with the FDA and their black box warnings, and even on everything. But I think that the conversation isn't even broached in cancer survivors or previvors, which is unfortunate. Like if you're done with your treatment, you're doing well, like, but you're struggling with hot flashes, night sweats. We know hot flashes, night sweats, they say it can't kill you, but we know actually, what, they maybe can, because they can lead to that metabolic dysfunction, that can lead to that sleep disturbance, they can lead to that cardiac issues that women do actually die from. So that all cause mortality is what we're talking about. And so
your listeners to make sure that so they because we're really comfortable with this data, but so patients understand is that what the data has shown is that women who are new to menopause, and if they start HRT estrogen therapy within the first 10 years ideally, that
right.
they have a wonderful window of opportunity to significantly decrease the risk of cardiovascular disease, dementia, certainly osteoporosis, as well as all the symptomatic and quality of life. So this is why we're hammering home this kind of cardiac thing, because there's very good data showing decrease in cardiac, deaths if women start estrogen, and all cause mortality, in fact. And the data that I just mentioned for the premature menopause, it's even more, it's more pronounced, those benefits, when you're talking about women who are going through cancer at a younger age, right? Or going through menopause at a younger age, right? So, and while you and I are 100%, I know, on board for our patients that, we have to always look holistically. Patients need, it's not all hormones, right? Aggressive lifestyle interventions, really, solid nutrition, weight bearing exercise, stress reduction, all of these types of good health. But to deny them one of the tools in our toolkit for dealing with menopause, to completely deny them any access to systemic estrogen therapy or the knowledge of what the data shows, is really not the practice of good medicine, um, at all. And so I think what I'd like to start out and just kind of say, like we always, like, we bring receipts, you and I, we always have our data, right? We're not just, spewing opinions, right? So, like, let's start with the thing that you and I are constantly quoting, the 2022 Menopause Society position statement. And so if you just read, like titles and, like, like the buzzwords, you'll see, okay, contraindication to hormone therapy, breast cancer, right? That's written as a contraindication. But we know everything in life is, there's nothing really absolute. There's relative contraindications to everything, right? There's very few absolutes. So if you actually go and you actually read, in the Menopause Society guidelines, and I'm just going to read it right to you because I think it's better to just hear. So, hormone therapy after breast cancer. And then we're going to talk about an excellent review article that looks at all the data. But this is what the Menopause Society says. 2 randomized controlled studies reported conflicting outcomes of breast cancer recurrence with hormone therapy. One study, the HABITS trial, did show an elevated risk of breast cancer recurrence in hormone therapy users, but it was only local or contralateral breast, no distant recurrence, and no increase in breast cancer deaths. It goes on to say, it says, although systemic use of hormone therapy in survivors of breast cancer is generally not advised, if symptoms of estrogen deficiency are severe and unresponsive to non-hormonal options, women in consultation with their oncologist may choose hormone therapy after being fully informed. Several observational studies in women with a history of breast cancer have shown decreased risks of recurrent breast cancer or a neutral effect compared with non-users. And mortality was reported to be reduced in breast cancer survivors who used hormone therapy. 4 meta-analyses reported similar findings. They do point out a confounding factor in all of these observational studies is that women who are at lower risk of recurrence might be more likely to elect hormone therapy. And point out that the Stockholm Breast Center study, which was a randomized controlled study, showed no effect on breast cancer recurrence in hormone therapy users relative to non-users after 4.1 years, and again at 10.8 years. So, that is just the little tidbits that are just in the Menopause Society. So when someone goes to their GYN or their oncologist and asks about this, and they say, absolutely not, it's dangerous, no, you can't. Well, just what I just read there is actually, no, it's a little bit more nuanced than that.
Nuanced,
And I think we deserve to know that information.
right. And I think that, where we lose patients a lot is, this whole, okay, active breast cancer, of course, contraindicated, right? But like when you're in this recovery phase and your quality of life is crap and you're not getting anywhere, bringing this data to your GYN or your internist or whatever actually may be beneficial. Some of them might not even know. I mean, Dr. Menn, tell us, like, you went through this. One of my big things and one of my key terms in my podcast has been, I'm here to educate so you can advocate. And so, like, how did you advocate for yourself? I mean, we're both, OBGYN physicians, we know the system, but we have also, we can very well fall into this, area where people still don't want to listen to us either, right? Like, they're, as a patient or whatever. So, I mean, tell us how you did it. How did you advocate for yourself?
Well, listen, I was with the average OBGYN, okay? I was afraid, certainly of recurrence. I, was ERPR positive stage 2A. I did have ovarian suppression. I was on tamoxifen. I wound up having my ovaries taken out because I carried the BRCA2 gene, went through premature menopause in my early 30s. And I, kind of was just under the assumption, like everyone is, that I couldn't, once I completed my tamoxifen, that was it. I couldn't do anything else. And I just had to suffer. And in fact, I suffered during all of my treatment, and nobody, my oncologist, my GYN, nobody ever helped me, even non-hormonally, with any of the side effects or symptoms, And honestly, this was obviously 23 years ago. There was even less knowledge. And I was just trying to survive. I was just trying to get through residency. And then I subsequently had a pregnancy and, then went back on my tamoxifen and was just and then got my ovaries out. And so I was just literally trying to get by. So just like other doctors, I was afraid. And it wasn't until I finally had my ovaries taken out and I went through finally severe surgical menopause. This was like the final, nail in the coffin, so to speak. And I was like, really, over 2 months, I just became really symptomatic. And that's when I got involved in the Menopause Society and started to educate because I realized I hadn't been trained in menopause. So that's when my knowledge started, but I still didn't advocate for myself, in terms of taking hormones. And let's remember, I actually went off my tamoxifen at the support of my oncologist, and I had a healthy pregnancy with very high levels of estrogen. Right? And so, so let's remember this, okay? And let's all, before we even get into the HRT after breast cancer, let's remember that now ASCO, American Society of Clinical Oncology, at their last meeting, celebrated the positive trial that, was very encouraging, showing that women with ER positive breast cancer could take a pause from their adjuvant endocrine therapy, have, 2 years, have a baby, high levels of hormones, get fertility treatments if they needed. And there didn't show to be any increased risk of recurrence or mortality. And I'll tell you, the data was there 23 years ago because they allowed me to do that. This was just a more recent randomized controlled study, but there's lots of data supporting that. So this is one little kind of piece of the puzzle that everyone should make them kind of question, be like, oh, so if they're allowed to get pregnant with
these
super
levels
high
that are,
levels, how come we can't give a teardrop, little tiny bit, to help them with symptoms and protect their bones and heart, right?
Yeah.
That was like the first thing I started to think about. But then number of years went by, and finally, when I read the book Estrogen Matters, so let's shout out, we both are huge fans of Dr. Avram Blooming and Dr. Carol Tavris, who wrote the book together, and they investigated.
Amazing book.
Yeah, amazing book. It's required reading for all of my patients, and really should be required reading for all doctors who care for women. So that book was the first time I really started to understand what happened with the Women's Health Initiative, what happened with the fears around just estrogen in general. And then they go one step further. There's a chapter. The whole book's not dedicated to breast cancer survivors, but there's a chapter in the book asking the very hard question: what does the data tell us about HRT after breast cancer? And so the book is amazing for the layperson or for anybody out there who wants to read it. But what I want to talk about today is this article, which we can put a link to it. And anybody can email me if they want a full copy, because this is behind a paywall. So it's called Hormone Replacement Therapy After Breast Cancer. It is Time by Dr. Avram Blooming. He was invited to be the guest editor for The Cancer Journal for May, June 2022. And he invited many different researchers and contributors. And there's a number of excellent articles. This one's the best, though. And in this article, he just basically reviews in a kind of very scientific manner that you can take this and print this up and bring this to your oncologist, and you could read this yourself because it's actually pretty easy to read. And there's some very clear charts that look at all the data. And it basically is what does the data show? Because you know what? That's all we want to know. And I think what we're going to talk about right now is going to surprise a lot of patients, a lot of people listening to this. So basically, he summarized 25 studies of breast cancer survivors given HRT, and what happened to the recurrence and their mortality, right? So it was.
Let's just do a side note. He's a medical oncologist who's been treating breast cancer since, I don't know,
he's in his
50 years.
50,
yeah, he's like for a very long time. And so he's been treating breast cancer. He says he put so many women into early menopause with his treatments. Then I think that this kind of woke him up. Hopefully he'll be on the podcast one day and can tell his story. But, he is a medical oncologist and he knows the data very well, and he treats these patients all the time.
Yes. And not only that, but his wife had breast cancer and his daughter had breast cancer. And it was when his wife had breast cancer and she was suffering with, the menopause after breast cancer. And she was really, really upset about her cognitive changes, her brain fog, and fears about dementia. Um, and it was when he really kind of asked himself, like, what are we doing to these patients, and what does the data tell us? So I need to have better answers for my patients. And this is what oncologists across the world need to start asking themselves, because we are in an arms race of starving women of their estrogen to treat their breast cancer, and then across the board making knee-jerk blanket statements on what they can do with their menopause. And it's honestly, it's based on fear and a lack of knowledge, and not based on data. And I'll say, and Dr. Blooming will say always, that we don't have perfect data on this. You and I know we don't have perfect data on women's sexual health, on general menopause, on hormone therapy management. We don't have perfect data. But God, we cannot wait for them to create perfect data. It's going to take decades, or it may never happen. So what we can do is use what is the data we have, not only randomized control studies, but yes, observational data, meta-analysis, other data points from pregnancy and other things. And, we can use all of that, and we can make a shared decision making with patients. So I think for me personally, it was his book and this article that gave me the confidence myself, professionally as well as personally, to go to my oncologist. And I basically told him what I was going to do. I mean, I didn't really get his permission, but he agreed with me and accepted and supported my decision, because he's an amazing oncologist, Abraham Middleman, here in New York. Um, but I know I'm privileged because I had that information and I was able to digest it. So I feel like more people need to get access to it.
Information.
But it
And
was a
before,
long time coming for me.
right, absolutely. And I think that before we go on, and I would love for you to review the
Yeah.
key points of this. We always talk about one thing when it comes to menopause care, and that is what they refer to at the recent conference as precision medicine, right? We do individualized medicine for each person, and there's no blanket way to treat people in menopause, right? Everyone has their own genetics, they have their own environmental factors, social factors, everything. And so we have to hone in on the fact that everyone's journey is different, and we try to do our best for each person. And it's shared decision making. Women are smart, especially midlife women, like they've been through a lot. And I feel like the end of the day, if you give them the information and you give them the data, and they understand their risk and you understand the risk, and we know that there's more safety than not, then they can make the decision and we can support it. We can say, like, yeah, you know what, this is not paternalistic medicine, we're going to support your decision, um, because you are well informed now.
Absolutely. I love your point about this theme of precision medicine. And that was the theme of the Menopause Society Conference: precision oncology, really precision menopause management, individualized care, risks versus benefits, and shared decision making. And when you have a statement that says breast cancer is a contraindication, that's not individualized medicine. Just like you and I know that, like, this idea that migraines with aura is a contraindication. No, it's a contraindication for using oral containing, estrogen containing birth control pills. But you can use, formulation manners and all these things. Yes, you can still use HRT. So that's just like a simple example. But the same holds true for anything in medicine, and certainly breast cancer, right? So, and I can promise doctors, oncologists, OBGYNs, and patients, it's actually not that hard. The data is not that hard to understand. This is not rocket science. I'm not super special. I'm not that smart. Like, I just cared enough to read a couple of articles. Okay, people, like, and this is also not data that is like coming out of like left field or from some weird sources. These are like, in the, established peer reviewed, medical literature. Yeah. Um, so I think that's really important. Um, so shall we get into what this super important thing?
The title says it all.
Yeah, hormone replacement therapy after breast cancer. It is time, right?
It's time.
It is
Yes.
time. All right. So, I mean, I think that, because I always think that Avram, I think he says it best. I mean, everyone has to read the article, and anybody who's listening here, it's behind a paywall. Well, if you email me, I will send you a copy of the article. Okay? But here, 25 studies of HRT after breast cancer diagnosis published between 1980 and 2013 are discussed, as are 20 reviews of these studies published between 94 and 2021. Only one of the 25 studies, the Habits trial, demonstrated an increased risk of recurrence, which was limited to local or contralateral and not distant recurrence. None of the studies, including habits, reported an increase in breast cancer mortality associated with HRT. And even in the habits trial, the absolute increase in the number of women with a recurrence, which was localized only, associated with HRT administration was 22. It is on the basis of these 22 patients that HRT, with its demonstrated benefits for so many aspects of women's health, is being denied to millions of breast cancer survivors around the world. I mean, come on. So, and then, so what I like to also point out, and you film this, right? Are people going to be able to see this
Yes,
podcast?
yes, yes.
So, and we'll make this available too. So here is a chart. Okay, here is the chart that shows the summary of the 25 studies of breast
Yes.
survivors. And so
Mhm.
it's very lovely because it lists all 25 studies, and it
Mhm.
lists the years, the number of patients in the study, and the type. And we know that we like randomized controlled studies, right? That's like
Right.
our gold standard. We don't have all randomized controlled studies. Some of these are observational,
Retrospective.
retrospective cohorts,
Yes.
prospective randomized, retrospective observational, but we're taking the data that exists, right? And when you look at the results as you go down the list, we've got reduced recurrence, reduced mortality, no recurrence, reduced recurrence, no difference, no difference, no difference, no difference, reduced mortality. You get the theme, right? So, I think to tell patients there's no safety data is not actually accurate. And then I think it's really important because the one study that makes all the oncologists and really everybody scared, and what made everybody get particularly fearful, was the habits trial. And the habits trial was stopped, I think, in 2004. So let's remember, it's around the time of the WHI. So the mood in the world, in the medical community, was really anti-estrogen, right? So we always have to think of like things in context of what's happening in the society. So habits comes out, and at the same time that habits was coming out, there was another trial called the Stockholm trial, which had the opposite results. They were very similar studies. You can read the article to get into the details here. But basically, habits showed an increased risk of local or contralateral tumors, but no increased risk of metastasis or death. But it's a super interesting fact about the habits trial that they were not required to get a screening mammogram or breast imaging before they entered the study. Okay. All right. So that's number one. All right. Number one. Number two, it was done prior to where we were able to tell whether patients were HER2 positive or negative. This is back in 2000. And for women who had early stage breast cancer who were HER2 positive, were not routinely being given Herceptin. I mean, treatment was really different then. Okay. And so when patients got randomized to taking HRT after breast cancer or not taking HRT after breast cancer, those two pools of patients, they were not separated or randomized or controlled for HER2 status, even nodal status they didn't do, and they didn't have baseline imaging studies. And you and I both know that if someone enters a study with a small pre-existing breast cancer that's not clinically detectable, right? Probably within 2 years, it might be detectable. And that's exactly when they saw an increased risk of local or in the other breast if they had an intact breast. But it's very interesting. They never saw any distant recurrence. So there's a lot of problems with that study. And it was published in the cancer journals, right? And so that's what the oncologists state. Some of the other data was published in like menopause journals or primary care journals. And so it hasn't trickled down to the oncology community. And at the same time that that study was going on, the Stockholm trial, which was a very similar population of patients, showed the actual opposite results, right? It showed no difference in. So to kind of like hold women to the fire based on one study that probably has its pros, but it has its cons too. Is that really good medicine? No. And is that fair to women, right? I just don't think it's fair, right? And so I think, and then he goes on, and there's also another table here, which is then there's like a meta-analysis. There's 20 other review articles besides these original research articles where they kind of looked back and did a meta-analysis of, various amounts of studies. And none of those review articles showed any increased risk when they looked back. Okay. So when your oncologist says there's no data and you can't have this, you have to push back and say like, well, actually, have you read the data? And then yeah, and then I'll also tell patients like, listen, none of this data is perfect, right? They are not long-term randomized controlled studies that are done on women who are being treated for breast cancer the way we treat them now, right? Because in 2000, this is 20 years ago, we were treating women different. So you have to remember a lot of, this habits trial, women were being treated differently, right? So that's something to kind of consider. And I think in the end, Samina, this is like reproductive choice and reproductive healthcare rights,
Absolutely.
right? Your body, your choice. And if
Yep.
some women have a very low risk tolerance, and I can tell them this, and they're really suffering with menopause and they're low stage, low grade, very low risk
Yep.
of recurrence.
Mhm.
They're like, no, Dr. Men, it's not for me. I'll never feel comfortable because I need the perfect answer that this will not cause my breast cancer to come back. If that's you, that's okay. I respect
Okay.
that. That
Absolutely.
was me for
We're
a
not
long
trying to push everyone to take hormones.
no. And if that's you don't like that the data is not perfect, I can tell you that the data is not perfect for anything that we do,
Yes. And it probably
But
will never be
and,
perfect.
and that's okay, but that's your choice. But it's not the choice of an oncologist or a GYN to say that you can't have that option when we
Right.
actually have supporting data that it might be safe. And then the other thing is I think that women have to really sit back and think of like balance. So I'll tell patients like balance things out. So here's on one hand, you're a breast cancer survivor and you fear recurrence and you want to live as long as you can. But on the other side, you might have lots of symptoms that are truly impacting your quality of life.
Mhm.
You also might be really concerned about heart disease risk and brain health and your sexual health and all these other things, right? And
Mhm.
you deserve to be able to weigh those things and understand that you're more likely to die of heart disease or get
Yep.
dementia when you're older or break a hip and die early than you are to have your breast cancer return. And so
Right.
you need to really, you've got one life to live. And I think you have a right to like balance those things out. And I can't put a value on those things, right?
Right. Right. Exactly. And I think that's what's important is that patients understand, but just having the knowledge that, you know what, if this is something that might help me and that is okay for me, then I'm willing to try it, right? Like if this is something that will improve my sleep, will decrease my risk of heart disease, you have to look at your other stuff too. Like, do you have a lot? Are you South Asian? And in the South Asian population, we're 25% of the world population, 67% of the world heart disease. And if you're a breast cancer survivor and you're South Asian, that heart disease is going to kill you more than likely before the breast cancer will.
And the
More than
diabetes risk, right? In South
Yes, and the
Asians, a
diabetes
very
too.
high
Yeah,
diabetes risk. And we know that HRT, 30% decreased risk of ever getting diabetes. And if you already have diabetes, it's going to improve your glycemic control, right? And so like 100%, this gets down to precision medicine, right? And like, so what I like to do too, one thing that I like to do with my patients is kind of like, let's, first we review their history, right? Then we review like, what's your recurrence risk? What is your oncologist saying is your risk of recurrence? Let's look at your oncotype. Let's look at your pathology. There's a wonderful tool that all of your patients should know about and demand that their doctors do with them. It's called Adjuvant Online Onco Assist. And this is for estrogen receptor positive breast cancer patients, but you can kind of type in all the details on your breast cancer and your how many years you had adjuvant endocrine therapy 0, 5, or 10 years. And it'll show you your 5, your 10, and your 15-year risk of recurrence, right? And so when I show that, I do that with patients. Some patients don't realize the benefits that they're getting from their adjuvant endocrine therapy. And they want to stop their aromatase inhibitor. They want to stop the tamoxifen. And I'll do it and I'll show, look, you've got such a good benefit. Let's find a way to keep you on it. Other people realize like, I'm barely getting a benefit of this and I'm really suffering. And it's been 4 years. I want to stop. I'm like, has anybody told you that you've got like a 1% benefit, but you have a huge risk of this prolonged ovarian suppression? That's something I do with my patients who are still in the middle of treatment. But then once you finish that, I think it's really important, like you said, to individualize, like, what are your health risks now besides breast cancer? Because you're more than your breast cancer. Look at your cardiac diabetes risk, get lipid, testing,
yeah.
get cardiac
Have you had a
testing.
coronary artery scan?
Yes,
Calcium
all of
score,
these patients
all
should
of
have
that. Yeah.
coronary artery calcium score. They should get a baseline bone density, really a comprehensive full picture look at their health.
Yep.
Then the next thing is, what are all your lifestyle things? Because we're always going to do those things first so that we can have a whole
Yes.
podcast on, right? Then
Mhm.
what non-hormonal things have you tried for your vasomotor symptoms? What have you done non-hormonally for your bone health? What have you done with local vaginal hormones for your sexual health? And for some women, you know what, if we can actually do some of those things, we don't have to go to the next step, to the hormone therapy, but we can. And if they want to, at any point, they can go to that next step, right? And so then the next thing is, well, okay, I've explained to you, what the data shows. We've, looked at all of your lifestyle stuff. And now, okay, if you would like to try hormone therapy, let's talk about the best, safest options for you. And I think for most breast cancer survivors, it's pretty much the same options that anybody would have. In my preference, it's a transdermal estrogen. Um, Along with a micronized progesterone. But I'm also a huge, huge fan of Duav, which is conjugated equine estrogen paired with basodoxifene. So it's back on the market. I think it's a fabulous option for breast cancer survivors who have intact breast in particular, because it's an estrogen paired with something similar to tamoxifen. It's not technically a SERM, but it degrades the estrogen receptor in breast tissue as well as in the uterus, so that there's no estrogen impact basically on the breasts, and theoretically no impact of it if there's floating breast cancer cells sitting out there. So I think Duav, a low dose patch, and with progesterone could be a lovely combination for these women. And that's what I did for myself. I started myself on the 0.025 patch with 100 milligrams of oral micronized progesterone at night with the blessing of my oncologist. And I will tell you, Samina, within 2 weeks, and I actually get teary eyed when I think about it, within 2 weeks, it felt like someone put a light switch on in my brain, in my body. I stopped waking up with joint pain. I had energy. I slept. My sexual health improved. My mood improved. My anxiety improved. And Samina, it had been almost 20 years. I mean, in my 23 years, I had a pregnancy. There was times when I was on tamoxifen and I was still having my hormones. Like I still had ovarian hormone production. I was not in menopause yet when I was on tamoxifen. Sometimes I used Lupron. For a number of years, I didn't use Lupron. And so I did have my estrogen. So it wasn't 23 years total of being in menopause, but there was a lot of, times of temporary menopause. But I was past that 10-year window. I'm going to tell patients. This is another thing that comes up, right? Because a lot of breast cancer survivors will be like, well, great, Dr. Menn, but now you tell me I'm past the 10-year window. Again, shared decision making, individual risks and benefits, right? And so for me, lower dose, a transdermal, I did my coronary calcium score. I didn't have a high cardiac risk. I felt safe doing it.
You
Been
can
a
do
year.
you can do that ASCCVD score, whatever your 10-year
I
or
did
point.
all of that. Yep.
Yeah.
And so, just like breast cancer survivors, women who are out of the 10-year window do deserve a shared decision making. So I
Yes.
was kind of both.
Yeah.
And when I tell you it's changed my life, I was
Mhm.
able to get off my Effexor. My
Mhm.
cholesterol is way better. I'm finally able to, like, my waist came back because now my exercise results are actually, efforts
Yeah.
are working.
Yeah.
Like,
Yeah.
I'm like a living lab of what I've found changes. And I feel good about my decision. And it may not be the decision for everybody. Um, and I'll probably get some heat for even saying this, but I'm willing to take that heat because it's ridiculous that we're not talking about this.
Right. And we have to know our options. You have to know your options. Everyone says menopause is having a moment, menopause is having, but it's not having a moment for breast cancer survivors or previvors because they're still being eliminated from the discussion, which was why this discussion was so important for us because I think that, and why what the work that you're doing that I love is so important because that's unfortunate. I think that breast cancer survivors, thrivers, previvors are still being left out of the conversation over and over again.
I'm
And
going
so,
to ask you in air. Me and another colleague, we are interested in writing up a protocol, an example of how you can, do shared decision making and how to counsel patients who are breast cancer survivors. And basically just like, what's a protocol that could be used that other providers could offer. So
mhm,
maybe you might help me draft that protocol up.
yeah,
So
would
we're so
love to.
good about shared decision making. So I feel like we
100%.
get two, healthcare providers out there who really are, passionate about helping women, all women, even breast cancer survivors deal with. And I know your specialty compared to mine is you really have such a great knowledge base on women's sexual health. And that's what I've learned so much from you. And I feel like that is also part of the reason why some breast cancer survivors might want to start hormone therapy, because talk a lot about the menopause symptoms, but it's also sexual desire, sexual health and wellness. And so, I think that's another part of it that, that's the next frontier, and also testosterone in these women, which I'm starting testosterone on as well. And that there is actually data in the Cancer Journal that Avram was the guest editor. There was a beautiful article about testosterone and breast cancer risk, and very reassuring. So,
Yes.
so I think we've got a lot of work to do, you and I.
Yes, let's do it. I'm down for this. So thank you so much for, coming on my podcast. You're my first expert and first first medical expert plus, patient story, which I love that,
Call
other
myself the
people
provider survivor.
providers. There you go. But, those are very important. Like I said, the only way we can learn to educate, the only way we can learn to advocate for ourselves is to educate ourselves. So that's what you and I love to do. We love to spread the word, educate as much as we can. And, there's going to be more to come. And Corin and I are going to work together even more, I think, in the future. So that will be great. And thanks for tuning in. We'll have another episode coming up with more information about, Women's Health Initiative. We're going to talk more about that and, everything to do with menopause, sex, hormones, and drugs. So we'll get into more in the upcoming episodes. So thanks for listening.